We will start with Dr. Charles Blair, followed by Jim Pitts, Dr. Jim Pitts. The next speaker will be Marcia Stickfort, followed by Sharon West, and Holly Jones will be our final speaker. And my name is Calvin Kelly, and I will serve as moderator for today's program, starting with Dr. Blair.
Good morning.
Good morning.
I'm Charles Blair, family practice physician. This year, my class reunion at Meharry will be celebrating 25 years. So I'm out of Meharry since 25 years ago. And just a side, actually my daughter is there now, attending her first year of medical school as well. At Meharry Medical School as well.
Good start.
So, physician at the Sisters of Mercy Urgent Care, and I've been in Asheville for the past 16 years. Also, I came to Asheville. I worked at the Buncombe County Health Center for 5 years, and right now I've been with the Sisters of Mercy for 14 years. I was asked to speak on the state of Black Asheville in healthcare, and for several years I've been collecting data on the racial and ethnic health disparities for Buncombe County, and been passing that out over the past several years. Whenever I get this information, I go to the center for the data collection, and I just get this information. I send it out to the public, the politicians, the clergy. And when it all boils down, the state of Black Asheville healthcare is poor. I have collected data as in the area of AIDS, homicide, infant mortality, diabetes, stroke, heart disease, prostate cancer, and breast cancer. And in the areas of AIDS and homicide, it's been consistently a grade of F. Overall, when it all said and done, if you boil it down, I would give, if you were given a grade, I would say the grade would be a D for Asheville. Not to depress you, because when I get this data, I get really sort of down sometimes. Every time I get it, I say, man, I'm working so hard and nothing seems to be getting done. And I get sort of down, especially when I get this information and I see we're heading in the wrong direction. But I went over this information and I sort of broke some things down, and I maybe draw some positives out as well. Let me give you some positive things that we can, go on. In the area of homicide, for instance, overall, the mortality rate has decreased since I've been collecting this data. The mortality rate has decreased over the past 3 years. Also, the disparity ratio comparing the whites versus non-white has also decreased over the past 3 years. So we like that is a good thing. We want to see that ratio decrease on a steady basis. Another good sign is in the area of infant mortality. Infant mortality rate of mortality has decreased overall. Infant mortality has decreased over the past 2 years. And this is great news right here. The disparity ratio for infant mortality has been decreasing for the past 6 years. Let's give a hand for that one. Okay. And so when I see information like that, I'm encouraged. Say we're heading in the right direction with infant mortality and homicide. Diabetes, the overall mortality rate has decreased. It's unchanged for the past 2 years, but the disparity ratio has increased over the past 5 years, means that there are more non-whites or blacks dying of diabetes relative to whites. In the area of stroke, it has decreased overall. It has increased. It increased this year, and the disparity ratio has also increased in a year's time. AIDS. Overall, AIDS has decreased. It has increased over the past year. However, the disparity ratio has been steadily high, increasing for the past 5 years. As of the data from 2001 to 2005, the disparity ratio for AIDS is 20. Basically saying 20 African Americans dying to 1 white. And that has increased from 15 last year, and before it was 14, 12, 11, 7, and 4. So you're going from a disparity ratio of 4 to now 20. In the area of heart disease, it has decreased overall, but the mortality rate is steadily rising for the past 3 years. And also the disparity ratio has also increased for the past 3 years. Sad to say, prostate cancer and breast cancer are the 2 diseases that have increased in mortality since I've been collecting this data. And however, the disparity ratio has decreased over the past year. I, give you this information not to depress you, because yes. Oh, times. Okay, thank you. Okay, all right, thank you. I'm gonna give you answers to the problem during the discussion.
If you see this young lady in the front raising her hand, that's Grace. She will be our timekeeper, so not to distract you, but she will be keeping us on time and on task. Thank you, Grace. Dr. Pitts.
Okay. Grace is the whip. I'm Jim Pitts, and I teach sociology here, but I'm also increasingly active in mental health field, but that's not my training. But, life has led me into it, and I'm involved in a grassroots effort to try to bring more attention and understanding to how serious mental illness is throughout the population, not just the black population. Serious and persistent mental illness, which includes chronic depression, okay? But also bipolar, schizophrenia, obsessive compulsive. They're now beginning to realize that autism, all of these are in the brain. And they are common part of the human experience as far as we know. It's not just a function of being black or being well-educated. I mean, there are all kinds of folk theories out there. Indeed, there are also some black people who think we don't have mental illness, that's what white people have. And it's not true. The only real issue is how communities and a nation responds to serious mental illnesses. That's really what the issue is. They're located in the brain. Now, as a sociologist, I knew nothing of this until it became a family issue. Sociologists look at how institutions work and big patterns. Okay, the whip says. But in any case, the stigma is the biggest barrier to dealing constructively. The stigma, the fear of being ostracized from your family, from your church, okay? Because churches have a long way to go in learning about mental illness and seeing it as a part of their faith. And we already know, and Dr. Blair's will document, that black people, poor people are marginal to healthcare systems, okay? So let me tell you just a couple of things here. How do we fail? We, all of us, fail collectively. One is in the families that run from it, won't deal with patients, churches that exclude, see it as being demonic, politicians who'd rather put money into building prisons and don't see that that is their mental health policy. Getting people off the street at any cost, as some business proposed the issue. Insurance companies have the right to discriminate, to exclude people with serious mental illnesses. I'm going to tell you as a fact. It's being contested in Congress now. But if they see your list of medicines, they will send you a letter and say, and tell you, quite frankly, we don't want to cover it. Now, what can we do to help in Asheville? I mentioned just a few things and get out of here. One is, what is being attempted is crisis intervention, CIT. You'll see more and more of that. AB Tech, the police, both Buncombe County and city police, are trying not only to train officers how to deal constructively with a mentally ill person, but also how to establish partnerships so that they can be diverted from jail. Police can't do it by themselves. We're going to have to get housing, public housing involved. We're going to have to get churches involved so that police are supported in changing their behavior. We need a crisis center here, and Western Highlands has just broken ground so that when people become psychotic, there's a place they could go, a couple of days. And finally, education. And it doesn't mean you have to go to a university. I represent the National Alliance on Mental Illness, and we're anxious to get more people involved because we can't just wait on the government to change. We have to be a part of the change. We have to be the ones who pressure both medical and governmental institutions and say, we want to change, and we want to be a part of that change. Left on your chair is some information. Anybody who wants to talk about it, be glad to do it.
Hi, I'm Marcia Stickford, and I'm on the Buncombe County Board of Health. And what I'm going to talk today is to kind of give you an overview of public health really quickly, and talk a little bit about how it impacts health disparities in our community. Public health performs certain very specific functions in every community. And in North Carolina, these are pretty well spelled out legislatively in terms of mandated services. One of the roles of public health is to protect the community. And we do that by restaurant inspections, dealing with outbreaks of hepatitis A, and flu vaccines, ways of keeping us, all of us, safe and disease-free, or as disease-free as we possibly can. Another role of public health is to assure that all of us are healthy, and to assure that that we have adequate access to health care. And there are some key mandated services at the state level that we're required to perform at the Buncombe County Health Center. While the mandated services are very specific, every community interprets those based on the community need. So in our community, what we've done is over time developed a set of services in response to the need in our community, in addition to some really key mandated services like child and maternal health. And what you need to understand is that some of these mandated services are like the bricks in our public health system, and some of them are like the mortar. That public health, part of our role in assuring public health is really to be aware of what the need is and to look at who's providing what services and to try to fill in the gaps as best as we can. An example of that is that we provide sexually transmitted disease services for a population of folks that generally don't get seen by primary care doctors. But that's an important service. It assures the health of the community. The other thing to remember about the set of services that we provide at the health center is that while they're mandated, the level of services and the way in which we deliver them are a community choice. And we've been very fortunate over the years in that we have a great deal of support from our county commissioners. Most of the funding for public health is local funding. Some of it comes from the state. But most of it is dependent on how willing our elected officials are to put that money into our budget to make sure that those services are there. And that's one of the things that I think as a community we can have a real impact on. There's a huge dedication both by our county government and certainly by the folks in our public health department to make sure that there's a safety net for low-income folks who can't be seen or aren't being seen by other health providers because of insurance issues and other issues. And what I think that we can do as a community is to be good, informed clients of the public health system. We need to know what the services that are being provided. We also need to know how much they cost because it's our tax dollars that pay for them. We, as a group, we need to advocate for our public health system serving as a safety net because as the statistics will show you, in Asheville, the residents of our community, there's this growing gap that there are a large number of African American families and individuals who are low income, who have no insurance or are underinsured. And these are the folks that public health is created to address their health needs. So as a community, we need to advocate for the funding to continue to go there. That our public officials, again, we have a very strong history of support for those safety net services through both the health center and other providers. But we really, every year, our county commissioners make a choice in how they budget the money. And so part of what the community needs to do is to be aware of what those safety net services are, how much they cost, and to advocate for continued funding because that is subsidized, government subsidized health care for people. And so we need to really keep an eye on it and we really need to advocate for it and make sure that there's a community discussion about it. Another role that public health plays is to assess the health of the community. And many of you may have been involved in the community health assessment we just went through. There's information on the back table about the process. We identified 5 priorities. Health disparities was certainly one of those priorities. The way we're following up on it is kind of twofold. One is that there's a work group, and it's the Institute for the Asheville Buncombe Institute for Health Parity is providing leadership, kind of moving through, developing a plan, kind of monitoring where we are. The second is on the sheet of paper about the health assessment in the back, there's a website, and the report for our most recent community health assessment, which was just completed in May. It's 108 pages. It has a huge amount of information. If you go there, you can download the entire report, and it's wonderful information. And that's the other thing the community needs to do is to make sure that our folks who are making decisions about these things are using good data, and that's one of our aims with the community health assessment. The last thing I'll very quickly say is the other thing that public health does is to promote the public health. And I just want to quickly mention 2 efforts to do this, to look at both policy and environmental changes around eating and moving more. One is Healthy Buncombe, And it's a community collaboration that's aimed at removing the barriers, especially that all of us, but especially low-income folks, have to eating well, because there are some significant socioeconomic barriers to people actually taking charge of their own health and starting to eat well and to exercise more. The other thing is on the school level, there's a group called the School Health, oh no, I can't remember what it's called, Martha, thanks. What? Thank you. Phew, this happens. And it is a joint committee, a council between both school systems with a lot of other health providers, and they're looking at making schools healthier. They've had a real impact on the policies that both Buncombe County and Asheville City Schools have had. If you go in there, the menus, what's served kids for lunch is much, much healthier. Kids, especially at the elementary school level and at the middle school level, are getting opportunities to move around more. So that committee is a committee that's aimed at really working with our young citizens and educating them and bringing them along so that they can lead healthier lifestyles and maybe avoid some of the health issues that we have. And I invite you to, there's also a pamphlet back there. There are a list of websites you can go to for more information. There's a lot of wonderful things going on, a lot of really terrific resources. And I really invite us to take advantage of what's already there and really partner with the work that public health is doing, because I think the story is very grim, but there are also resources, and as a community, we're really showing the will to do something about this. The fact that we've identified health disparities as a priority, and the fact that we're looking at ways of removing barriers to kind of everyday people leading healthier lives. And so I invite you all to get more involved. Thank you.
Okay, I see I'm going to have to play Sandman with this group up here. You all may remember Sandman from Night of the Apollo, right. I'm the son of a Baptist minister, and I know what people can do because they can keep going, and I see Grace raising her hand, and they just keep on going, so I will be playing Sandman. So we will go on with our next presenter.
Grace, if you would just hold these up for me, please. This is my warning. I have to create this, so. Good morning, everybody. I'm Sharon West, and I am a registered nurse of many, many years, and I want to say that I'm very pleased to be in the presence of my teacher, Dr. Charles Blair, which he will never say that. He's just very humble. But we're talking about healthcare disparities today and the issue, the urgency of healthcare disparities. I am also the president of the Asheville Buncombe Institute of Parity Achievement, which you have a brochure on your table, on your seat. Something very interesting happened to me, I guess about a month ago, and that was when I was in a conversation with a very well-known corporate executive, and we were talking about issues affecting the Black community of Buncombe County and essentially the whole United States of America, because to be quite honest, it kind of mirrors each other. And we were talking about a few things, and he asked me a question. He said, "So Sharon, is there anything to that disparity thing?" And Dr. Blair has taught me tact, and basically what I said is, that's a great question.
That's a great question. I like
And
that.
this is an entree. This is the entree to what we're facing here in Buncombe County. And as a matter of fact, if you look across our nation, you're going to find very similar statistics, even though the populations of African Americans may vary from place to place. And that's a little crazy, but it's also very real. We're talking about real time. We're talking about real issues and real people. The World Health Organization has defined health as a state, a complete state of physical, mental, and social well-being. Not merely the absence of disease. See, sometimes we have a tendency to focus on the low-hanging fruit, which is health. But you see, if I don't have money to take care of some of the expenses so that I can be healthy, then I realized even more that health is indivisible. It's all related. So when Dr. Blair's vision came into vogue in 2000, when he developed the Asheville Buncombe Institute of Parent Achievement, which we call a BIPA, he knew that. And when he invited me on to just kind of take a look at what was going on, it was very real. And it became even more so real. Even being a nurse for over 27 years, sometimes you just kind of don't focus on issues unless it's brought before you. And we got to see firsthand how people should not be divided. See, long ago, we had primary care. Primary care physicians are almost extinct. African American primary physicians are definitely almost extinct. Fortunately, this is what Morehouse focuses on, is the training of primary care physicians, African American physicians. But when we got away from the primary care, when you would go to the doctor and the doctor says, tell me all about what's going on with you, let's treat your whole body and not just your head today, your heart next week, and your feet, and you know, when we divided that out, the person got lost. So this is what a BIPA is all about. We have developed parity action teams that focus on different areas that are very important to people to bring back that wholeness. And essentially, I want to read something real quick. I'm going to try and make up on some of your time. I'm going to help you out, Grace, and be real quickly. Basically, this says, in a nutshell, what a BIPA is basically all about. You know, empowering people and getting people to take ownership of what's important, and getting and creating and bringing back the fragmented self and bringing it back in wholeness. Go to the people, live among them, learn from them, love them. Start with what they know, build on what they have, but of the best leaders, when their task is done, the people will remark, we have done it ourselves. Because when you bring people together and they become a part of it, then they take ownership. See, black people, we have been trained to take care of ourselves. It's a part of who we had to be. It was where we were forced to be. And so we need to just kind of stimulate that again and get people involved in the issues to see where they fit, what is their piece of the puzzle. You see, it's kind of hard for African Americans and Latinos and my American Indian brothers and sisters to really fit that definition of wholeness by the World Health Organization, complete wholeness, because we're tad fragmented now. And see, when I read articles like this one that came out in a magazine, you know, I used to have to wear these glasses. I used to read the Journal of Clinical Oncology that says many older blacks of lung cancer don't get the same treatment as whites, even when they have equal access to specialized care. When I read this article that my husband found for me in Charlotte Observer, disparity found in cancer screenings, women of color less likely to get regular mammograms. What's going on with that picture? You see, even though this has been going on for a while, it ain't fixed yet. We still have a lot to do. And of course, when the Institute of Medicine released their landmark study, Unequal Treatment, Confronting Racial and Ethnic Disparities, when for the first time in history, institutional racism was called for what it was. They shot straight from the hip in 2002. And basically what they said was, racial and ethnic minorities tend to receive a lower quality of health care than non-minorities, even when access-related factors such as patients' insurance status and income are controlled. In a nutshell, it's telling me that if I walk to a hospital and I have insurance and I'm making fairly decent income, and my white counterpart walks into the hospital with the same symptoms, my white counterpart will get more quality treatment, more better treatment than I do. And I can verbalize and say what I need to say, and I can tell them my symptoms. But because of who I am and how I look, I won't get the quality care. So what is the definition of health? Thank you.
Well, I just want to say amen and amen to Sister West with those words. She really captured a lot of how I see the issue of health and the concerns of health in this community. My background actually is in public health, and I didn't know I was going to be on this panel till this morning when I walked in, but I do have a few things to say. I think I was asked to be on the panel in terms of my policy-making hat, and truthfully, the city of Asheville does not, that's kind of not our purview. It's more the county and the state, but I do think there's a couple of things that you can hold our feet to the fire about that would help improve the health of our community. And I'm looking at Miss Minnie Jones here, and I think actually it was in this room, in the corner back here in a little breakout group, that she was saying, well, city, why don't you make that connect that sidewalk from Reed Center down to the ABCCM, so people walk, and then they have to get out in the street, and then they have to get back in. And a year and a half later, I'm having to look her in the face, and that sidewalk's not there. And it's on the list, though. It's on the list. But I think that's part of the things I do want to say in terms of the policy realm, which is having a community that is walkable, that facilitates movement and exercise. I think personally we should focus on the areas where most people are walking, but particularly where most people, the walking is their main mode of transportation. So, so anyway, that's our number one priority. One of our number one priorities on Asheville City Council are more sidewalks and greenways. And I just want y'all to know that's not frill stuff, that's real life health stuff. And that's why it's there. The other thing I'll say really quickly about the city of Asheville, and it's, we get a little credit in the policy department, but primarily it's from our staff, is that several years ago, within our human resources, they came up with, in our risk management, they came up with a project called the Asheville Project. I'm looking at our star pupil here, or example of success. It's actually going on the road on a tour, but basically it's a work site initiative that the city of Asheville does with its employees to promote. It started with promoting the management of diabetes, and it offers help with a pharmacist and help with medications, but it also says, here's how you eat better, and it's begun to say, and here are ways that you can get involved in exercising more too. And like I said, we have a huge success story on the second row here, but there's a lot of success stories. So I would also say that part of this story here today is for us to work with our work sites to help facilitate those types of programs. And I would say, where do you start? Well, you start with work sites that have a large minority population. That's just my opinion on that. I was excited about one other little commercial before I do my last little wrap, which is one of the things I'm excited about in terms of this community is this newspaper right here, the Urban News. And in November, they dedicated the whole issue to healthcare, and there's beautiful Miss Sharon West up there in the corner. And that's how you start. You start talking to your community about, like, what's the deal, and this is a big part of the conversation too. But it can't stop on February 17th. It has to keep on. So I'm very excited about this magazine. One of the things I liked about this magazine too is that they profiled a program with the YWCA. And the YWCA's mission is the empowerment of women and elimination of racism. And so trying to get our heads around, elimination of racism, how daunting is that to even, say out loud? It's a very humbling thing to articulate. But one of the programs that we're working on has to do with the wellness, and that's the part that I know the little more about, is the kind of wellness and prevention. And 3 or 4 years ago, we started a diabetes wellness program, which targeted minority people that have diabetes. And because what we realized that was missing in the community was a focus on how the role of exercise can promote people's qualities of life. We have great, education, even though we can talk about some barriers to that too. But in terms of the exercise, and we thought we want to be out there, we want to be that place, and it's had great success. Part of the reason why it's had success is because of the support group and the mentorship that we've built into the program. So now these women and men that have been our models will help bring other folks along. One of the great success stories is Mr. Lon Debman, and he lost 80 pounds, and the management of his diabetes is just amazing. So we hired him to do our diabetes prevention program, which is trying to get even more on the front end of things and say, okay, before people have been diagnosed with diabetes, let's start working with when folks have a couple of indicators. Once again, we're focusing primarily on minority and low-income communities. I would give you those phone calls and cards and definitely check us out, but we're full with a long, long waiting list. So I'd like for us to get more resources so we can have more classes, because it's a very intense program, and there's a lot of, that's part of its success, is because it has a lot of connection with people. One last thing. I got 3 minutes. Okay. One of the things that that Marcia talked about at the end was about the school lunches, and I just want y'all to think about this statistic for 2 seconds. For children, for African American children, this is from the CDC, born in the year 2000, it is estimated that if we keep going the way we're going, and we don't change our behaviors and our policies and the way we live our life, 1 out of 2 of those African American children will have diabetes before they graduate from high school. Now, y'all, that is not okay. So that is why I'm excited about what's happening with the school system. But we've got to do more. We've got to do more in our small institutions. We've got to do more at the YW with the snacks that we eat, and how we're building the communities and getting our kids moving. That is the way we're going to stop this trend, because it will also cripple us financially. So hey, you don't have to be a Sandman for me. I'm done. But I appreciate the privilege of being here.
Okay, thank our panelists for those comments, and now it's your opportunity to participate in the discussion as well. We do have a mic that will be floating around, so if you have questions, comments, or statements for our panelists, here's the opportunity for you to do so. So if you will raise your hand, we will bring the mic around.
Okay, guys, also, if you're not comfortable with speaking in public, we also have cards being passed out, and just write your stuff down on that, and we'll take it up to the facilitator. All right, we're going to start out here. Alton King, right? Yes.
Hi, I am a recent MBA graduate from Wake Forest University, and my mother is an end-stage renal disease dialysis patient, and healthcare is a personal passion of mine. My question to the panel is, how do you look to overcome healthcare disparity with all the talk of containing, controlling healthcare costs?
I'd like to give each person a minute to respond, or those that would like to respond. I know.
That's the tough one.
I'll start a certain direction. And I want to suggest that we force people who believe that and say that to indicate more clearly what they mean by controlling it, because that has helped to produce the disaster we're experiencing now, is a mindless focus on control which is directed at the population. It's directed at middle class, it's directed at very poor people, and sometimes we buy into that. It sounds real great, but we don't have the same adamant position about controlling the destructive forces of war.
I have worked in several different areas, healthcare and juvenile justice issues, and one of the things that I've always found frustrating is that for a while at every conference they'd give that story about how, you know, somebody's standing on the river and they're watching all these people floating down and they're pulling them out, and they go up and they try to stop people from falling in. And one of my issues is that we don't put enough resources at the front end, that we don't look at how do we actually prevent this. And there's a huge body of research now that shows, like, diabetes is preventable, or you can moderate the impact that it has both on people physically and on people's lives. And we just need, as policymakers, as a community, we need to really be pushing for kind of moving the resources down there. At some point, it's going to have to happen. And it may mean increase in taxes, it may mean that we lose some ground on some other issues, but with health, there are ways to prevent bad health outcomes. And we need to have the political will to do that. And I guess in a community as small as ours, in some ways, where the focus is so clear, because the statistics that Dr. Blair showed you, when we looked at what the priorities are, the health disparity statistics are really among the clearest. So I just think that's politically, we need to tell our elected officials that we want to see more health promotion and health and preventing disease.
I want to speak on this on two levels. One is the World Health Organization ranked the countries in the areas and how they give health. And the United States are ranked number 37 in the countries. Actually, France was number 1, Italy number 2. Number 39 was Cuba. And we are the nation that we spend the most money than anyone in the whole world on health care, and we're still ranking at number 37. Now, the countries that rank the highest in the best health care in the world are those countries with national health insurance. So I'm saying that we must push for that, push people, our politicians, put those folks where we want them to be with that desire for national health insurance, if that's what we want. And then there won't be that tier system that we have in this country where someone will get the Cadillac care and someone get the lower care. Now, on the other level, we must take our personal responsibilities as well. We must eat right, must exercise. And so, in that way, we must, do this at an early age so that hopefully we can, cut back on these, the dialysis and amputations, treat the diabetes correctly, high blood pressure correctly. And so we have to take personal responsibility as well.
Thank you.
I would just add 2 seconds about, my new thing is school lunches. This is my new thing. But in terms of in how it would relate to policies, and what if right now, our people in our cafeterias have to make it all work mathematically around these reimbursement rates for federal food that just don't get it. I mean, it doesn't promote fresh fruit and fresh vegetables and all the things that could be in that preventative front end. So that's one way that you can kind of start thinking about that prevention early on.
And if I might add to this really quickly, there are a few points that I like to piggyback on too. I have a tendency to put a lot of focus on the ethics of healthcare when we look at distributive justice, or should I say distributive injustices. Who gets the care, who's going to get the referral, and we have a lot of that that's pretty much rampant in our society. So when we increase the representation of minority healthcare professionals, then we have advocates within the system that can help direct the care and the treatment plan of those needing that care. So we do need to put focuses on increasing minority, ethnic and racial minority representations. And then the other thing that our society need not continue to look at the people as the problem, but the asset to solving the problem. So.
Amen. Okay. We have a question from the audience, and then I'll read a question from the card.
I think this is Jackie Fitzgerald.
On the topic of bringing healthier food in the cafeteria for people in school and people who eat in the cafeterias in their, when they're working in the day. Sure, sorry. I was talking about the issue of bringing healthier food into cafeterias and schools, and I feel like it's it's important to get away from the major global food companies who dominate the industry of passing out food to prisons and schools, and who provide the same poor quality food that people buy in restaurants and grocery stores and fast food restaurants and things like that. And I think that's an important thing to consider when talking about bringing healthier food into schools and promoting healthier lives. Because again, it's those same companies whose best interest is maybe profit over people and not being conscious of how much sodium or sugar or whatever is going into the food that's creating those health problems for people. So.
And I'm bad at names, and maybe somebody on the panel can remember, but there's actually a collaborative effort locally with the Wellness Trust Fund, and they're actually working with local farmers to bring fresh produce into the schools. I mean, there's an active project, and I think while we're a long way away from being perfect, the State Department of Public Instruction has really done a lot of policy work around this, and every school system now has to have a policy that looks at changing the way that folks are eating and making sure that kids are moving right. And we've got some good partnerships locally that are working on that now. We've got a long way to go. I think Holly addressed some of the issues that are a real barrier to doing what you're talking about, but I think that if we can figure out ways to partner across all communities, we are a community, we've been designated a fit community. There are efforts along these lines that are being made, especially with children. We are one of the only counties in we are the only county in North Carolina that during health fairs with kids, we're doing BMI, we're collecting body mass index information on all of our children. We are able to look at kind of what the weight statistics are, because obesity is definitely a predictor of a lot of health issues. And we're really developing some good strategies and talking about ways can we do really targeted strategies for populations of kids. And certainly obesity is a major issue for African American children. So I'm not saying that, I'm not telling you we're there, but there are some good efforts being made, and you're absolutely right. It has to happen.
Okay. A question from the audience. Can you speak to or talk about the safety net services at BCHC, and how do people get involved, or how do they advocate for those services? Anyone on the panel?
I don't even know that. The safety net services, we operate a primary care clinic that actually, and again, we've done a pilot. We also provide behavioral health screenings as a part of that clinic. It's on a sliding scale. It is aimed at working with folks that are underemployed, and underemployed, yeah, uninsured or underinsured. We essentially, by law, take all comers, and the one thing I'll say about Buncombe County Health Center folks is that these are people who really believe in that everybody should have the same standard of care. There's a real effort to reach out to the community, and these people are passionate. They could be working someplace else than in public health. They're really passionate about it. That being said, it is a subsidized service that's paid for mostly by county money. There are a lot of competing, there are a lot of challenges with government, competing interests, looking at different ways of spending money. And we are, again, very fortunate in Buncombe County because the health center is a partner with a hospital, with a medical society. We've got project access. We're really looking at ways of dealing with the safety net issues. I know that there are meetings on an ongoing basis, but the fact is that the statistics show from the community health assessment that one of the things we were aiming at was for every every low-income person to have, everybody in Buncombe County to have a medical home. And those, we did a really great job for a little while. We're now going downhill again. There are fewer, we're now to the point where fewer and fewer folks are finding a medical home. So the point that I want to make is one of the things that we can do is to advocate with our elected officials that we as taxpayers feel that we do need to subsidize health care for these folks, that it is important, it makes a huge difference to us and to them, and that has to stay there. I'm not saying that they're ready to do away with it, it's just that they need to continue to hear from us as taxpayers that it's a priority for us.
I want to give you one last little bit of data. Buncombe County, despite having a lot of active and creative people, like Marcia and so forth, when it comes to mental health per capita, we rank between 75 and 80 out of 100 counties that make up North Carolina. And this is Buncombe County. We're not Mitchell, we're not the rural counties, we're not the poorest counties. But when it comes to mental health, which permeates every issue we're talking about here, you can't mobilize people who are psychotic. You can't mobilize people who are deeply depressed. You know, what I'm saying is, I showed you a tape that shows you where some of them are ending up. But the point is, it's in the schools, it's in the homes, it's in the housing. If you want to deal with homelessness, you better deal with people's disorders. They're total disorders, and Buncombe County could do a lot more relative to its wealth base.
Thank you. I know there are a lot of hands up and we will get to you. So please, if you must, write your question down so you don't, or your comment down so you don't forget. We do have cards. We have a question over here, and then we'll bring the mic on this side.
This is Belinda Grant.
This is not so much a question, but at the end of the paper has where do we go from here? And we do know that knowledge is power. And for those of you who are not aware, I am speaking on behalf of the Mount Zion Community Development, which is a 501c3 nonprofit and affiliate of Mount Zion Missionary Baptist Church. We do have an infant mortality initiative called Project NAV. And those of you who are aware of African American pregnant women, no matter what the age, please refer them to our program at the Mount Zion Community Development. We also, Marcia, I would like for you to come out and talk to our teens. We have a teen pregnancy prevention initiative. And the eating habits are not so well, and I would like to get with you to talk about that initiative. But we do have resources in Asheville, and we have been around since 1998 to reduce infant mortality. And we have only had one infant death since that time. So please refer to Mount Zion Community Development at 350-9821. Thank you.
We have a question up front here. Right over here.
Thanks for being here, everyone. I have a question about data. I read in the newspaper, I don't know, one day last week that nationally cancer rates are down, it said, both in terms of incidence and in terms of deaths. And I had to ask, how do they know that? Here we have almost 50 million people without insurance. We have people who don't go to the doctor when they're sick. CSI does not come to our house when somebody dies. So, you know, there are a lot of just in terms of cancer, I know there are a lot of people who are suffering from it and dying from it who are not being counted. Now, you've got Project Access here. You do have more of a community network in Buncombe County than a lot of us do in other counties. So maybe your data is a little more reliable than what's out there generally. But I'd like you to speak to, you know, how do you know that you're really getting a handle on the scope of problems and disparities, and whether or not we're improving at all?
Thank you.
Well, the community health assessment is a state mandated process. It happens every 5 years in the community. We just finished our third cycle of it. every year we try to do better. And we collect secondary data from a lot of different places, and we also do primary data collection. We do phone interviews, we've done focus groups, and we actually, especially since health disparities was a priority in 2000, we did what's called an oversampling. We called up more African Americans and we did more focus groups with them, collecting more information. It's not perfect, but one of the things that we're doing by putting it up on the website, and I really invite you to get that web address and look at the report, is we're trying to pull as much information as we can bring together so the community is making better decisions. And I think that is at the heart of it. And in my opinion, you don't make good choices unless you got good data. And there is a group that this year we're trying to make the information more accessible to everybody by putting the report online. We're trying to get a group moving forward that looks at the data in between, especially on the 5 priorities that we set, and I'm not going to remember all 5, but they're also on the page, but health disparities is one of those. We're trying to get individual work groups who will identify a set of indicators that we maybe can do a better job collecting local information, because that's certainly, you do statistical analysis, the state does statistical analysis, but the truth of the matter is if we want to make good local decisions, we need to have good local data. And around mental health issues, I mean, there are a lot of issues that we're really not doing a good job with. But what I can tell you, because I've been kind of yelling the same thing for 10 years, is that we continue to try to focus on a way to do that. And the problem is there isn't a lot of money for it, but we've got some ideas about building different kinds of partnerships, maybe with UNCA, maybe with some other folks, so that we can collect that local data so we can really have a clearer picture of what's going on here.
Okay. Yes,
Yeah,
Dr.
thank you for the
Blair.
question. This data that I have is on mortality rate. What I would love to see is data that we can use in a proactive way. Instead of measuring the mortality of diabetes, let's measure the hemoglobin A1Cs in patients and monitor that and be proactive and work on that. Let's measure cholesterol, high blood pressure. Instead of measuring infant mortality, let's measure infant birth weight and try to work on being proactive. This information, we're years behind when we get the information. And I would say let's stress collecting data that we can do something about.
I know we have questions. I'm going to read one from the audience. On the subject of prevention and promoting health, are you aware of any programs to improve conditions of homes or worksite conditions in regards to environmental health hazards, i.e. mold, pesticides, chemical exposures, lead paint?
I'm going to totally shoot from the hip here. In terms of, I do know that there was an initiative, and actually Mr. Isaac Coleman he's around, I don't think he's in this setting, but that has been involved in going into homes and not monitoring, but assessing that. So from the lead point of view, I do think there's, and I actually think you access it through UNCA.
Yeah.
Is that?
And that's still ongoing.
Yeah. Pardon me?
Yeah.
Talk to you.
There's a lead prevention program,
Oh.
but I was wondering if there are...
There's others. Oh, I just heard the lead. Sorry.
Okay. So
I'm
we
not
don't-
aware of any.
is-
Focus on just worksite conditions, home conditions as it relates to health and its impact on health.
Okay. So is anyone in the audience aware of other programs? Yes.
And that's the most organized effort, I think.
Hi, my name is Joanne Smith, and I'm the program manager for the PACE project, and this is one of Dr. Blair's bright initiative ideas that has finally taken place here in the community. And we're not looking at mold per se, but we are looking as one of the underlying efforts and effects of health disparities. We're looking at the social economic of individuals, looking at their ability to find employment, but also how employment impacts where they're living in stable conditions, but also how those underlying factors play into health disparities. So we are looking at those efforts.
Thank you.
I have brochures in the back, so if you please take one on your way out. Thank you.
Thank you for that. Go back to our audience question.
Poor Bob.
My name is Judy Poor, diagnosed diabetic 9 years ago. I have found that low-income, elderly, senior citizens like myself that have had to get food stamps as a stability for eating, it costs more to take sugar out of food than it does to put it in. And food for diabetics costs more, but each year the food stamps go down. To whom do we direct and ask about things like that? Health and Human Services, or how do we deal with it?
The link between socioeconomics and health, I think, is one of those things that as a community we really do need to address, and that you can't, low income is a barrier to living a healthy lifestyle. I mean, we just need to accept that folks that live in low-income neighbors, research shows that they have less access to supermarkets, food stamps. You're absolutely right. It doesn't support a healthy lifestyle. Some of those issues are state and federal issues, but I think that's the link between health and economics is something we can discuss locally and look at are there ways of subsidizing and kind of filling in that gap so people are able to eat healthy.
Okay. Question from the audience. Why do we not hear a discussion about mental health in the Black community?
You got it?
I don't have a definitive answer, but I think it is the stigma as well as the lower educational achievement. The more you learn, the more active you become in society and you find things. And I'm going to refer that to answer this to Randall Richardson, who's got some real career experience and knowledge about this.
Thank you. I'm Randall Richardson with Mission Hospitals. I served as director of psychiatry for a number of years. I want to talk briefly on a couple points I heard. Gentlemen, with respect to cost containment, we as a panel and an audience need to be aware Medicare was cut in the president's budget. That has significant impacts on Medicare and Medicaid coming back into our communities. That is horrific in the time of the challenges that we're having. Next, we need to understand that healthcare is a profit machine. And pharmacy, before drug even reached the market, we're spending close to $1 billion in R&D. Hospitals are shifting their costs. So the burden is, in a sense, is being shifted back to us that are already being challenged. And our incomes are not keeping up with the rates of inflation. But I want to go back specifically to mental health because it is a passion of mine. In the early 90s, many of you all will recall Pete Domenici and Wellstone, who introduced health parity with respect to mental health. Those type of bills have languished in Congress, and we have to advocate because what's happening is that our health care insurance folks are profiting tremendously on us. Even before we get into discussion, 25% of the money allocated is in administrative fees, and the rest is negotiable. So when we talk about mental health, what's happening is we're running actuary tables on people's lives. We'll determine utilization of benefits and how much profit we can make on them. And it's something that's horrible to talk about, but we need to be aware where the money is going and who's making the highest margin. And that's in your Blue Crosses and your Blue Shields. And that's in these privately held companies that are profiting over negotiating and brokering exactly what they think you need relative to what you should be receiving. And so the mental health piece is advocacy that when you have mental health, it should receive the same coverage as your regular health care provider. And we have to advocate. And last, John Conyers, our senior congressman from Michigan, introduced H.R. 676. And Dr. Blair, to your point, sir, that is a bill in Congress for universal health care coverage. And hopefully with the next administration, we'll see that bill pass. Thank you.
Thank you.
My concern is that we talk about health parity, but we're really not serious about it. And my reason for that, thinking that way, is I don't see black folks in positions of middle and upper management in the administration of health. And I think that that has a trickle-down effect to us getting the adequate health care that we need. And I think when I see black professionals getting fired, having to move to other positions, that sends a message to me. And so I'd like you to speak to that and what can be done about that.
Okay. Anyone on the panel?
In the area of healthcare, that speaks to minority recruitment and retention. When I arrived in Asheville in 1990, there were 5 African American physicians in Asheville. Ron Caldwell, still here, thank you, Ron. Albert Anderson, Dr. Holt, Otis Michael, and Dr. Parham, and I mentioned Dr. Holt as well. 5 African American doctors. Today, there are, after going on 17 years, we have 7. And Dr. Holt is semi-retired. I don't know, Ron, is he still seeing patients? Or they're very loud. Okay. And we have Dr. Robin Wright and Dr. Thompson, who has recently come on board as well. So that's all I got to say about that.
Oh, let me add something to what the two of them said. What I've learned about mental health payments and Medicaid is that in private practice, psychiatrists can draw down $150, $200 an hour, okay? Within Medicaid, they're paid $60 an hour. And given the hassles of basically the fragmentation of mental health services that's going on, one way to begin to turn it around is to begin to pay doctors somewhere close to what they can make in private practice. If this is going to be privatization, then pay for it. If you keep the rates at a fourth or a third, it's not just that you won't get black physicians, you won't get certain kind of physicians and specialties. And so there's a hypocrisy at the highest levels about so-called privatization, because when it comes to low-income people, they're unwilling to spend the tax dollars where the need is greatest.
Jacqueline, would you like to share a response with that as well?
Yeah, I work with Mountain Area Health Education Center, and we graduate probably, we have 3 residency programs, 2 family practice residency programs, one here in Asheville, one in Hendersonville, and an OBGYN residency program. So we have faculty, and we also have a new fellowship, and we're opening up a new dental residency program as well. And I think out of all those sources, we have 1 person of color. And we graduate probably, Randall, what would you, is Randall gone?
He's over there.
We probably graduate 16 physicians out of the residency program annually, not every 3 or 4 years, but annually. And we've been in the residency business of training physicians in Western North Carolina for over almost 30 years. And I believe we've had 1 African American graduate.
Lori Campbell.
Yes, 1. And we've had several Hispanic Latino, maybe 3 or 4. I know we have a couple practicing. Jose Gonzalez, Dr. Robert Fields are still in the region. And we have no faculty of color. And so for physicians to even want to come to a community like ours, then they would like for their advisors and mentors at least to have some color in the faculty. It's very important, and I'm sure our physicians that are in the room can speak to that. And so we have a possibility of bringing more, but even though I worked there over 11 years and have tried to advocate for that, I've not been very successful. And as far as mental health professionals, my God, I don't think we have any. And so if we have such a high level, if the majority of the people are people of color that are suffering from mental health, and we have no mental health professionals, and we're 75 out of 100, you know, just do the math, do some thinking about that. I just wanted to.
Thank you for that. We're going to go back to our question here and make our way around the front here. We're going to try to get to 5 minutes before the hour and dismiss you for lunch. I'm asking that you write your questions. We probably will not be afforded the opportunity to get to everyone, but please write your questions on the cards and we will forward those questions to the appropriate panelists to get a response of some sort to you.
Yes, I'm a psychiatric nurse practitioner. Actually, I was part of the old Blue Ridge and also New Vistas. And I guess in saying all this, I have a few things, I guess, first off. One is I can speak, after 20 years of working in mental health, to the fact that there is a lot of disparity. But I guess the big thing for me is here in North Carolina, I'm actually licensed in 3 states. I saw a failure to look at other states that actually did the privatization before, you know, North Carolina, unfortunately. As you all probably know, the state plan being the 3 phases that it was, as you addressed the fact that there's very low incentive for folks to go out there and be that type of provider. And it's actually to a place now that we're actually glad to see Medicaid, because the insurance companies are so hard to get the money from for anything that we're actually welcoming Medicaid. The IPRS funds is a huge problem. New Vistas lost over $2.5 million, which actually contributed to their closing because of the fact that poor funding that was happening. And I guess I was kind of wondering too, when you look at the military funding versus the health funding, because I'm understanding I'm in the, you might say, international human rights class here at the university, and that's one of the perimeters I'm understanding that you look at. I'm kind of wondering what it is here in America, especially looking at how we've reallocated our funds here lately, and I'm wondering if all of you know of that. And for the healthcare, just because I think the one thing maybe in all I have to say that might actually be addressed in this room, for a long time I have folks, because I work community mental health, and I put on things like Depakote and lithium, which requires labs. Unfortunately, we have that working poor and that donut hole now in Medicare, so we can't even get a lot of things. I try to send them to places like the health department, but unfortunately they can't do labs unless it's actually a person who's actually receiving a service from them. And I understand the problems with the funding, because I have many times said, well, you know what, that person has seizures, so why don't we just let them take care of that so we can get labs? But anyway, I'll go ahead, because I realize there's a lot of time here constrained, so if you could just address that. Thank you so much.
Thank you for your question.
I'd like to have clarification, please. Clarification. Please. Did you say
The
there was
actual-
no
yeah.
disparity?
Oh, no, I think there's a lot of disparity.
Oh, okay, I'm sorry.
Yeah,
I
yeah.
misunderstood.
Oh, no, there's so much disparity because actually just getting reimbursement because of mental health.
Okay.
And actually even myself, I walked into a deli counter one time just dressed like this, and I got a big disparity versus how I'm dressed at work.
Thank you. As we're coming to bringing our mic to the next person, question from the audience: what can we do to combat institutional racism and public health in Buncombe County? To the panel.
Well,
not everyone at the same time.
I don't have the great answer, but I got one part. What students have found, they've done some real digging. I mean, some of the things that on the chair there, some they got from me, but they did a lot of the digging, is that when it's convenient, big institutions don't have the data. colorblind becomes very convenient when they don't want to document what is happening. Now, I'm not saying all institutions have good data, but I'm saying some of them that you think would have color and ethnicity data about basically groups that are known to be suffering in American society. They, him, they, her. I got to get clearance to give you that information. So one of the things you could do is to begin to demand the data. If they don't have it, they can learn to get it. But we have to cut through what color blindness does to those who are being shafted.
Thank you, Dr. Pitts.
The problem with data, I tried to get data from this community. I had to go to Raleigh to get it. I was shut out. And when I presented this data to the community, it was not very well accepted the first few years. But that was one of the first things, is one, data collection. If you can't get it, you need to go somewhere else to get it. Two, increase awareness. Dr. Maddox, cardiology, was not happy with the data that I collected. So this is back in 1997. He'll tell you this, because he's already spoken for an audience as well. He was going to prove my data wrong. So he did the data in the hospital. And he did this research about amputations, cardiac casts. And Dr. Maddox, September 1997, was on the front page of the newspaper, Asheville Times, saying blacks receive less quality care than whites. And today, Dr. Maddox is one of my strongest advocates. You know, he's really on top of trying to achieve parity in the area of healthcare, especially with his cardiology group. So those are the things that you can do to help with institutionalized racism.
I think we also, as consumers, people need to be willing to call it what it is, not just in the public health system, but in the public education system. I mean, in a lot of different places. And in my opinion, it comes down to having different expectations. That when a patient, and I think that Sharon was referring to this, when a patient walks into a room, a lot of times is a shortcut. Certainly healthcare professionals, but teachers do it. Everybody, to a certain extent, does it if they're honest. You know, I've talked to a number of folks who had the experience of going into a doctor and we're not asked, we're not asked the same questions. We're not given the same instructions because it was already assumed that they weren't going to change their diet, they weren't going to exercise. And so I think that one of the things that we have to do, and that's when I talk about folks being informed, educated consumers, is African American folks, I mean, all of us should do the same thing, but when you go into see a doctor about a condition, you need to do some research or go to somebody who has some information who can advocate and train you, but you need to make sure those people are asking you the right questions. And you know, you need to go look it up on the internet or talk to somebody who's got the same condition and make sure that those people are asking you the right questions. And again, I think this cuts across a lot of social services issues. And then if they're not doing it, you need to hold their feet to the fire. You need to complain about it. You need to go to somebody who can advocate for you to complain about it. The only way it's going to change is if we call people on it. We can do all the cultural diversity training we want, but there are so many people who don't believe that they actually do that. And I'm here to tell you, I do it. You know, I have expectations of how people should behave, and that colors my interactions with them. And people need to call me on it. I mean, that's how I change. That's how everybody changes.
Thank you. Okay, we're going to take, thank you. We're going to take a final question from the audience. Okay. Sharon?
I just want to say one thing that, well, maybe a couple things, but anyway, just to say that it sounds so good to say I'm going to advocate for myself. It sounds so good. But when I hear my patients tell me, Sharon, I said everything you told me to, I had the list ready, and they labeled me as a difficult patient.
Right.
They didn't want to touch me. They didn't want to. They said, well, you need to find another doctor. Do doctors actually say that? Yes, they do. So when you have an 80-year-old patient or a 60-year-old or a 20-year-old who's been stereotyped already because of what the 20-year-old has on, or maybe they are saying this, that, and duh, but they can tell you what's hurting in their body, which you need to formulate the care plan from that complaint, but yet that's blocked because they've already been stereotyped and measured up. When you have a 50-year-old woman that says, my feet are hurting and it's tingling and I can't feel like I used to feel, who knows that person's feet better than that person? But the doctor says, oh, you don't have diabetes. We don't need to test for that. Just get a new pair of shoes. And down the road, they are full-blown diabetic. When you have people that are trying to advocate for themselves and follow through but are being blocked. Institutional racism, at one point in time, we could look at racism and racist, and we could identify them because they would say and stand strong. But now racism has become such an institution, it has become so gray. And then our response to their voices is, you have perceived you have been discriminated against. So what do? We have to educate our people, but yet have those few, the sprinkles that you see on the top level of administration, or should I say the sprinkle of the black person that you see on top level administration, must have backbone enough to say, we need to make some changes. But until you have that, until administration sees it as an issue, we can have the most beautiful care plan, we can have the most beautiful discussions, but unless administration, the top, sees it as an issue, and unless the community, and hey, let's get the faith community back involved again, because that's the only standing African-American institution with any strength. But then we have to redefine strength nowadays. So there are issues, but it's all of us working together.
I just make one comment to that, because it's not just the African-American folks who are up at the top, it's also their white counterparts who have to be the ones who are going to be willing to say,
Absolutely.
this isn't right.
Yeah.
And they have to be willing to be the ones who are willing to stand beside
That's right.
African-American.
Yeah, because usually there's one African-American at the top. That's why I say the sprinkle.
Okay, I know I said we were going to have time for one more question. Before, I would be remiss not to introduce to you the people, the students that pulled together this healthcare portion. I'm going to ask Rachel, Grace, and Burton to come up, please. And so I will afford them 30 seconds each, and I know they're good students, so they will be able to handle this, unlike, I won't point to anyone. 30 seconds to say what this project meant for them, and then I want to afford you the opportunity to carry this discussion and dialogue on into where are we eating at? Alumni Hall. So I want to afford you the opportunity to continue this discussion. My last thing is, my grandmother used to say that knowledge, she hated the saying, I should say, that knowledge is power. And she would always correct me and say, no, knowledge is not power. It's how you use the knowledge that you have that makes you powerful. So what will we do with what we've done here today? It's going to make us all powerful. Thank you.
Hey, my name is Burton Salthouse. It was an honor that Dr. Mullen had us in this class. He had a hand-picked, selected class, and he let me in. It was an honor to work with you guys over email and contact and such. I just want to say this isn't over. We're going to have one of these every year, hopefully, from here on out, so we can examine the state of Black Asheville every year. This is a starting point. So if you guys have questions, please write them down. We will address them in our publication as we publish. So Thank you.
I'm Grace Salzer. I was also very honored when Dr. Mullen approached me in November to take part in this class and in this conference. You cannot look at this data without being affected by it. I believe all of my research group came into this aware that we would find disparities, but we were surprised by just how disparate the rates in fact were. And I think we were surprised by the barriers to finding certain information. It shouldn't be that hard to find good information on healthcare, and I hope that we can work to improve this in the future.
Hi, my name is Rachel Williams. I'd just like to say that this project for me has been an opportunity to take my loud, proud drama student self and use that for my adopted community of Asheville to make a difference, to make this better, because it does not take, a rocket scientist or a graduate student or anyone to see that these are problems. But what it does take is a united community to create solutions. So thank you for coming. Thank you for helping us start to create those solutions with you, for you, together. The cards are in the back. Please, if you have any other questions, any other comments, concerns, anything, let us know so that we can address those as well. Thank you very much.
Again, I want to say thank you to our distinguished panelists that participated, and as well as all of you that came to this presentation. If you will go out the doors to your left, that's where the buffet is set up, and thank you all again.